All right, good morning, everyone. Thank you for joining us today. I'm Nicole Rawl, Communications Director at the Connecticut Hospital Association. If you're here for the press conference to talk about our legislative priorities ahead of the 2024 legislative session. This meeting is being recorded and it will be made available afterwards. We ask that you keep your mic on mute, which I think pretty much everyone is. We know the Zoom rules. There will be questions at the end taken from the press for our speakers. When you're asking a question, of course, feel free to unmute, and you can either raise your hand or put your question in the message. Today, we are joined by Jennifer Jackson, the CEO of CHA, Jim Iacobellis, our Senior Vice President of Government and Regulatory Affairs at CHA. And we're also joined by some really great experts from our hospitals across the state. So we have Ena Williams, the Senior Vice President and Chief Nursing Officer at Yale New Haven Hospital. We're also joined by Barbara Durdy, the Senior Director of Policy and Regulatory Affairs at Hartford HealthCare, and Todd J, the Vice President of Accountable Care and General Counsel at Griffin Health. And today we're going to share more about our priorities as well as what we're experiencing in Connecticut hospitals across the state. So with that, I am going to turn it over to Jennifer.
Thank you, and good morning, everyone. Thank you for being here today to hear about CHA's 2024 advocacy priorities. As Nicole said, today we want to talk to you about the way that the legislature and the governor and his administration can continue to be key partners with hospitals in providing high quality, affordable, accessible care. We want to outline for you the issues that we expect to be part of the dialogue in the upcoming legislative session. Certainly supporting healthcare workers is key. We need to grow our healthcare workforce and we need to eliminate workplace violence. We need to invest in communities to improve their health. We need to support hospitals by addressing Medicaid underpayment and reducing regulatory and administrative burdens. And we need to protect care by avoiding any policies that harm care delivery and access. Hospitals are the cornerstone of their communities. They provide care to anyone who needs it 24/7, regardless of their ability to pay. They support over 200,000 jobs. And they bolster economies as purchasers of local goods and services. Hospitals' positive economic impact to Connecticut is $38.7 billion, and they provide community benefit contributions of $3.4 billion. But hospitals are facing enormous challenges, a critical healthcare workforce shortage that, as Nicole said, we're going to talk about today, staggering financial hardships and negative operating margins that have been worsened by the pandemic and historic inflation, and systemic cost drivers over which hospitals do not have control, such as insurance practices, administrative burdens, and chronic underfunding by government payers. It's essential that we all work together to have strong hospitals in Connecticut. That's what we'll be looking for this session, and I'll turn it over to Jim Iacobellis to talk about things that we can do, actions that we can take.
Thank you, Jennifer, and welcome and good morning. Jennifer actually mentioned some of the issues, and I'm going to quickly highlight those, but also talk about others. And first and foremost, we need to support our healthcare workforce. I think you will hear that as a consistent theme. We need to make sure that they are safe. We need to make sure that they remain in the healthcare field, and we need to ensure that we have a pipeline of healthcare workers. And there are ways in which we can do that. Increase funding for loan repayments, in ways and provide individuals who are already in the healthcare profession a career ladder to move forward. So we need to continue to do that and support our workforce. We also need to support our patients and support our hospitals and communities. First and foremost, we need to fix the certificate of need process. The certificate of need process is a process under the Office of Health Strategy, which makes determinations on services that hospitals can provide, as well as deals with equipment that hospitals, and I'm thinking there of imaging equipment, but we need to fix the process. It's taking too long. The timelines need to be shortened. We need to create an expedited process in certain areas. We need to create an equal playing field between hospitals and other providers, entities in the healthcare field. And we need to reduce the duplication and streamline the process. We need to support telehealth flexibilities. We know that during the pandemic, telehealth became a lifeline for many patients, and we need to make sure that those flexibilities are made permanent. And we will look forward to working with legislators during the 2024 session to do that. We need to continue to invest in behavioral health services. The legislature and many partners work together for landmark legislation for behavioral health services for children in the previous session. We need to look at expanding those services for adolescents and adults. That's extraordinarily important, and we'll continue to work with legislators there. As Jennifer mentioned, we need to fix the Medicaid underfunding, and we want to be part of that conversation. And we know it will be a conversation going forward. We know currently, according to the Office of Health Strategy, the Medicaid pays 62 cents on the dollar. Medicare is up is 74. So we need to spend time, and we need to fix that, which will enhance hospitals' financial stability. We need to make sure that we don't enact any legislation, as Jennifer said, that reduces access to care and further strains and erodes hospitals' financial stability. So we're going to be really focused on all legislation that we think will do that. Hospitals are in a fragile financial position, and we need to do everything that we can to make sure that we support them and don't further erode those issues. You know, as our conversation goes on this morning, we can add some more detail, but I just want to reinforce supporting the healthcare workforce, fixing the certificate of need process, supporting telehealth flexibilities, investing in behavioral health services, fixing the Medicaid underfunding, and making sure we don't enact legislation which reduces patients' access to care. Nicole?
Thanks, Jim. So now I'm going to introduce Ena Williams. Ena is the Senior Vice President and Chief Nursing Officer at Yale New Haven Hospital. And Ena is going to talk a little bit more about the workforce challenges that we're facing and the importance of improving workplace safety, recruitment, and retention. So Ena, go right ahead.
Thank you, Nicole. Good morning, everyone. I'm really delighted to be here to share some thoughts on the two areas of focus. How do we protect our healthcare workers? And really, how do we continue to ensure that we have adequate supply of individuals well prepared to do the work that we need in order to deliver the kind of care that we know that everyone deserves? I want to begin by suggesting that if everyone believes that healthcare is a right for each citizen of the U.S., and of course, Connecticut, that a robust, growing, and prepared healthcare workforce is essential to ensuring that delivery of, and I would add, equitable healthcare throughout our state. And I don't think we need to understate that. Now, I know that this is not a new crisis. No one here should be surprised. This has been a national crisis, especially since the pandemic. Might have been lingering before, but really was exacerbated by the pandemic. And Connecticut is not unique in the challenges that we are facing. There have been a number of initiatives across the state over the last few years, and especially also through the Connecticut Hospital Association, focused on increasing the opportunity to prepare more healthcare workers. We can build on investments already made to expand educational and training programs, ease the paths to careers in healthcare, support retention, and enhance the safety of our current and future healthcare workers. And I'll just expand on a couple of those in the next few minutes. Protecting our healthcare workers continues to be a top priority. These are individuals who have dedicated their lives to caring for those who are most vulnerable. But we must, and I will use the word very strongly, we must ensure that there are stronger laws that can hold people accountable for violence against healthcare workers. No healthcare worker should ever have to come to work and worry about the fact that someone is going to harm them while they're trying to deliver the best care that they can. The airline industry has done this, and I think that we can continue to be an example in Connecticut in following suits. Organizations are working tirelessly to put added strategies in place. However, these come with added cost to hospitals and healthcare facilities at a time, as you heard Jennifer and Jim talk about, when hospitals and facilities are struggling financially, especially post the pandemic. So providing funding support, such as grants, for example, would help facilities to improve on their workplace safety initiatives, and in the process, also help to attract and retain healthcare workers. We need to continue to build on this CHA-wide patient and family code of conduct that you may have heard of last year when that was launched towards the end of last year. And this is really a statement and a stake in the ground that says healthcare for safety for our healthcare colleagues is a top priority. And so continuing to partnering on that initiative is an area that I encourage us to continue to work on. In the area of attracting and retaining our workforce, according to this Connecticut Center of Nursing Workforce, a 22 report, the average age of the registered nurse in Connecticut is 47, actually down from about 52 a few years ago. So that tells you that a number of our nurses have retired and have moved out of the workforce. This means that we're beginning to see an influx of newer nurses into our healthcare industry. And of course, that comes with added responsibility, added training, added support that we need for our nurses. So as we continue to focus on attracting and retaining, and I'm just using nursing as an example, we also have a big challenge in our state with surgical technologists. We used to have 4 schools, now we have 2. This is a place that I think we need to continue to pay attention to, as these roles are really essential to running our surgical areas within our hospital settings. And so continuing to invest in those kinds of careers would be important. And I just bring those up as 2 examples. So I'll just highlight a couple of ways that we can, as we collaborate together, how to continue to provide support for attracting and retaining our workforce. Funding opportunities to support the ongoing recruitment, retention, and preparing of the workforce, as I mentioned. Support approaches that create healthcare career pathways and reduce barriers to careers and healthcare opportunities. Supporting the expansion of scope of practice for advanced practice providers, and absolutely supporting our academic practice partnerships, because we do have a supply and demand issue. There are individuals that want to be nurses, and there are not enough seats in the state of Connecticut to support that work. And so working with our academic practice partners to support that pipeline is going to be really, really critical as we move into the future. Innovation in care delivery models. I think Jim talked about telehealth and how we continue to fund and provide funding resource. Again, this will help to reduce clinician burnout as we redesign care. And I want to close by saying that these issues are not unique to Connecticut, but I believe that our combined collaboration can lead to successfully addressing our issues while creating a model or example for others to follow. And so I challenge us to keep leading the way. Thank you.
Thank you, Ena. I'm now going to turn it over to Barbara Durdy, who's the Senior Director for Policy and Regulatory Affairs at Hartford HealthCare. And Barbara's going to talk a little bit more about the Certificate of Need process that Jim spoke about earlier. So Barbara, go right ahead.
Thank you, Nicole, and good morning, everyone. I really appreciate the opportunity to speak on this very important subject. As we all know, healthcare providers excuse me, across the state are focused on improving access to high quality, safe, and affordable healthcare. Our goal is to ensure that patients receive clinically appropriate care in the most cost-effective settings. And when access to healthcare is delayed by overly burdensome regulatory requirements, our communities suffer. As the healthcare industry evolves, it is important to periodically evaluate the Certificate of Need process to ensure that it does what it is intended to do and that it does not impede access to needed health services to the communities we serve. The Certificate of Need process works best when the process is predictable, timeframes are certain, and the process is administered in a consistent and efficient manner for all participants. Creating a regulatory framework which ensures all residents have timely and safe access to affordable healthcare services is essential. Protracted agency review periods make it extremely difficult for healthcare providers to effectively plan and deliver healthcare services to the communities they serve. In particular, in cases where there is an identified community need or a compelling clinical need, these applications should be reviewed as expediently as possible so that patients in crisis can be diagnosed and treated more timely and efficiently. In short, the regulatory process should support our efforts to provide access to affordable, safe, and high-quality services in all communities throughout the state. Thank you for the opportunity to speak about this important subject.
Thank you so much, Barbara. And we're also going to have Todd J next, who is Vice President of Accountable Care and General Counsel at Griffin Health. Todd's going to speak a little bit more about the importance of addressing community health issues, how hospitals are working to address social influencers of health and the challenges that we face in the state of Connecticut. So Todd, go right ahead.
Thank you, Nicole. And I'm pleased to be with you today to share why the work that Connecticut hospitals are doing is so critical to the future of our state. Hospitals are working to partner with their communities to advance the health and not just the healthcare of the people that they serve. We know that only 20% of health is influenced by the healthcare that people receive in hospitals and doctors' offices. 60% of health is actually influenced by our environment. So things like poor nutrition, air quality, living conditions, the lack of economic stability have a far greater influence on health. And we know that Connecticut has some of the greatest disparities in wealth, which are often disproportionately affecting communities of color. The reality is true in the community that Griffin serves too. We serve about 110,000 people in 6 surrounding towns and cities. And some of those cities are fortunate to have fairly low unemployment, safe and affordable housing, and families that have a good median household income. But in Ansonia and Durdy, which are the 2 cities that border the hospital, they are some of the most economically disadvantaged communities in our state. 50% of households in Ansonia and Durdy don't make enough to meet their basic living needs. And this creates challenges for those families, other agencies that are working to support those families, and certainly for the hospital. Griffin was selected several years ago to participate in a demonstration project that was sponsored by the Centers for Medicare and Medicaid Services called the Accountable Health Communities Grant. The demonstration project went for 5 years, and during that time, we screened patients who came through our emergency department for social needs. We asked about food insecurity, whether they had stable housing, whether they had money to pay their utilities, whether they lived in a safe environment. And what we found from those screening activities was pretty shocking. More than 1 in 3 people that we screened told us that they had underlying social needs. And about half the people that screened positive told us that they were food insecure. Now, that was a wake-up call for us, and we knew that we had to do something to address that problem. So Griffin is fortunate to be part of a community that has a number of community-based organizations that work closely together. It's important because the work that we do around social needs takes a village. So when we realized how dire the need was for people to have access to food, we reached out to other agencies in our community, like TEAM, which is the federally designated anti-poverty agency that serves our region. And when we started looking more closely at how much food and the kind of food that local food pantries had on their shelves, we were shocked again. First, they didn't have enough. Second, what they had were often donations from local supermarkets that were highly processed foods. They had a lot of calories, a lot of fat, and a lot of sodium. They didn't have fresh fruits and vegetables. They didn't have meats and dairy products. And people were happy to take the Danish and the leftover breads, but those were the kinds of foods that were making their chronic diseases like diabetes and hypertension worse. So we work with team, we work with the local food pantry leaders who were extremely committed people, but just didn't have the resources. And we put together the Valley Food Security Initiative. And for several years now, Griffin has been purchasing food at its expense to help stock the shelves of our local food pantries with fresh and nutritious foods that those food pantries lacked. We leveraged a local relationship with a food distributor called Bizzuto's, located in Cheshire, to buy food at wholesale cost, and that allowed us to get a lot more bang for our buck. Every month, we have a trailer of food that's dropped off at a local warehouse, and volunteers from the community, including Griffin, gather to unload that food, break it down into allotments for food pantries, and then load the trucks that come from the food pantries to bring it to those locations. And so this collaboration has had an enormous impact, but it's not enough. We want to increase the number of food deliveries that we're doing to 2 per month. We're hoping to do that soon, but we know that even that probably won't be enough to meet all of the needs that people have. And so that brings me to the final point that's really important for the future of communities and the healthcare system in Connecticut. The work I just described that we're doing with team and Bizzuto's and the food pantries is being paid for by hospital operating funds. No one is paying us or reimbursing those costs, and we believe it's the right thing to do, but the needs are so great, and the demand for this help is far more than we have the capacity to provide, which is why we need the state to work with us on a comprehensive Medicaid reform package so that we can build a system that gives hospitals and their local community partners the resources to make investments like this. So I want to thank you for joining today's press conference and your attention to these really important matters.
Thank you so much, Todd. At this point, we are available to take questions from the press. So please feel free to either raise your hand or send a chat, and I will make sure we get to everyone. Any questions from anyone?
Nicole, it's Brian Scott Smith here, a freelance journalist. Perhaps I can. Sorry, I couldn't find where to put my hand.
Yeah, no, sorry. I was like, no questions. Did I mute everyone? Thank you.
So I've got a question, really for Barbara and also for Jim with regards to the certificate of need process. I want to put this to Barbara first. Wasn't there a task force review back in 2017, Barbara, of the certificate of need process, and there were changes made then? So are you saying that despite the 2017 review that you want more changes again?
Yes, there was a review, and thank you for that question. Yes, there was a review in 2017, and there were quite a few recommendations, as I recall, that were put forward by the committee. Not all of them were implemented. And so, yes, we still have work to do from that task force back in 2017, and there are more changes that need to be made.
Yeah. What specifically, can you be a bit more specific as to what things, because Jim mentioned about imaging, but, looking at the task review report, I think, the getting of equipment and imaging, there was going to be less oversight on things like that. So, can you give us a little bit more specifics as to what it is that you want to see change in that certificate of need process? Because obviously it's there for a reason.
Yeah, Brian, this is
Oh,
Jim.
go ahead, Jim.
Yeah, I can handle that. And thank you. Thank you for your focus on certificate of need because it is important. That review, you're correct. It was done in 2017. A lot has changed in the healthcare environment since 2017. But let me get to some specifics. The process itself takes too long. So no one is saying in any way, shape, or form that the Office of Health Strategy should not do the review and do the appropriate statutory review, but it needs to be done in a more time-efficient way. So we need to put deadlines in the process where there aren't deadlines, and we need to go back to where the certificate of need process was a number of years ago, even before 2017, that there's an absolute deadline, that if a certificate of need is not approved in a certain time frame, that the application becomes approved. And Barbara touched on when she talked about an expeditious process. We need to take a look at specific types of services and specific types of things that are under the certificate of need review and create an expedited process. And you mentioned imaging. We believe that we should create an expedited process so the acquisition of a new piece of imaging equipment or the modernization of a piece of imaging equipment to go from one modality to dual modalities doesn't go through the full certificate of need process. It's an expedited process. That's an issue that I think we've spoken about for a number of years, and we think that is important. We also think that from 2017 to 2024, the healthcare landscape has changed and has changed significantly. We have new players in the healthcare field, whether they are investor-owned entities or whether they are corporate entities. And we believe that if hospitals are required or others are required to go through a certificate of need process, that these other players are as well. It should be the issue itself, not who the entity is that is involved. Acquisition of physician practices is a great example, Brian, that hospitals are required to go through a certificate of need process for acquisition of physician practices. So we should make sure that any other entity that is acquiring a physician practice is also required to go through that. That's a second change. And as hospitals and other providers answer questions to the Office of Health Strategy, we need to go through the laundry list of issues that are required to be determined by the Office of Healthcare Strategy with a look on to make sure that there aren't duplicate items. And make sure that, questions from the first round of questions are different than the second round of questions, to do the best that we can to make the process as most efficient as possible. I saw a question pop up in the chat related to would an expedited process limit community benefit, so community input. I think there is absolutely a way to craft it where if there is community input and community concern, that we take the time to address it. But there are a lot of certificate of need applications where the community is in full support and no one is opposing it, that still take too long. So in addition to looking at the types of services, whether they are behavioral health beds, substance use beds, that we may think about going through an expedited process, I think we are clearly supportive of those applications where there is concern, that we spend the time to address the concerns. But we shouldn't have the same time frame for all types of certificate of need applications.
Can I just do a quick follow-up question with you then, Jim? I mean, specifically, let's look at a couple of issues then. The closing down of maternity and labour wards, which requires a certificate of need, and also, obviously, the acquisition of other hospitals. Yale, I will pick on specifically because they are currently waiting on a decision with regards to 3 hospitals that they wish to purchase. I don't know if Barbara wants to maybe weigh in on, sorry, not Barbara, if who's there from Yale? There isn't anyone from Yale, is there?
Yes, there is.
But But I mean, if you wanted to weigh in on that, Jim, about those things, because they're big items. I mean, closing down a service like a maternity or labor unit is a big deal and has caused a lot of controversy in certain parts of the state because of people saying, well, then I won't have a service available to me. And then, of course, as I say, with regards to the Yale situation, I mean, I know there's been criticism of the state by CHA and other organizations saying it's taking too long, but they're saying, well, this is 3 hospitals, not the usual purchase of one. So can you talk to us about, those 2 items?
Yeah, Brian, I'll pick up there, and I'm not gonna talk about the specific applications, but I will address the issues because it's inappropriate for CHA as well as for any of our other individuals who are speaking this morning to get into a specific certificate of need application. When I spoke about an expedited process, we are referring to those services where there isn't community concern, there isn't objection, or there is a specific need that we must get service up and running. And I use the example of behavioral health or substance use or the acquisition of certain types of imaging equipment, those types of services to look for an expedited process. And probably wasn't clear. I do think that even in those areas, if there is community concern, we should have the process and spend the time to do it. However, I think there is concern that we have, that the hospitals have, and then I know that many legislators have, that the process does take too long. And yes, there is a difference between acquiring a piece of imaging equipment, and yes, there is a difference between moving a clinic from one part of the town to the other. Then the acquisition of 3 hospitals. I think no one is saying that they need to take the same amount of time, but we are saying that they are taking too long.
Thanks, Jim. I just want to see if there's any other questions out there. Just want to make sure we give everyone the opportunity to ask. Paul Hughes. Let's see. Let's see if I can unmute you, Paul. Paul, do you now see the option to unmute? Not, you can definitely put your question in the chat. Okay, so why are you unwilling to say that the Yale acquisition isn't contributing to this proposal when there have been complaints about how long it is taking?
Paul, I think we have been talking about this issue in the length of time for the certificate of need process for a number of years. And I think the certificate of need from Yale New Haven and Prospect is providing, I think, a very stark example. But this is an issue that we've been talking about for a number of years. And if you go back to, I think it was 4 years ago when the legislature increased the filing fee for certificate of needs to make it a sliding scale, that those that are more complicated, we're going to have a larger filing fee. But the thought behind that was to provide more funding for more staff to speed up the process. So this concern we have had it for a number of years, but I do think some of the certificate of needs that are pending are just additional examples of that. I also wanted, Nicole, if I can, there was a question in the chat related to the provision of rural health and its relation to the certificate of need. And I think I want to talk about it this way. You're welcome, Paul. I want to give compliments to Comptroller Scanlon, who has done, I think, significant work with stakeholders on a variety of issues. And one of the issues has to do with rural health. And we have to make a decision in Connecticut, and I think every other state is facing that, is how do we provide the services in the rural parts of Connecticut? We don't fall into any of the federal designations at the moment for rural health. And if you would talk to colleagues across the country, when we talk about rural health in Connecticut, they kind of look at us strangely. But we have rural parts of Connecticut, and we have to have this conversation about what are the types of healthcare services that we have in the state, and then how are we going to pay for them? Because it's different, it's more expensive in for transportation. It is more expensive for physicians, and it's harder. So we, or compliment the comptroller for the beginning to have this conversation about how do we identify the issues related to rural health, and then identify how, as a state, we make the decisions to pay for them. We're seeing a beginning of that with the Office of Health Strategy in its new, I think it's their facilities plan to take a look at where all the services are in Connecticut and what do we need. And the next question is, how do we pay for them? And then how does that fall in line with all of the other work that we are doing with healthcare?
Thanks, Jim. We do have another question. I apologize, Lisa, that I skipped your question earlier. Amelia asked, someone had mentioned the need to expand mental health services for children to adolescents and adults. Can you expand on this? What specifically are the needs you are seeing?
Yeah, I'll touch on this, but we may have to get back to you with more of a subject matter expert on this. But we spend a lot of time with our colleagues in the hospitals who every single day try to provide the best care that they can. We know that when it comes to behavioral health services, that we do not have enough beds in the community. We know we don't have enough beds in the hospital to treat the patients and the needs. And that's only one part, right? I always think of behavioral health and I sort of think about it in three lanes. The first lane is sort of the prevention. How can we work with patients to prevent them from going into crisis? What are the services that patients need, whether you're a child, whether you're an adolescent, or whether you're adult? What are the services that you need to just maintain your daily living as an individual with behavioral health issues? And we need to make sure that we have the appropriate services in the community. But then when a patient goes into crisis, whether you're a child, you're an adolescent, or you're an adult, what are the services and where are the beds that we can provide you with that care, hopefully short term, to stabilize the crisis, and then to provide you sort of the post-hospital care. And then how do we then provide the post-hospital care? What are the community services that are out there, and to make sure that they are accessible to everyone? So, Nicole, thank you for dropping our behavioral health priorities into the chat. So it's those three lanes. We've been working with the state on what are new creative ways, and there are some areas that are just getting up and funding assessment centers, so patients can come to an assessment center, not directly to an ED, and maybe work with them there. One of the things that we have to deal with in that area is to make sure that the funding which is provided for behavioral health services was provided under ARPA dollars, which we know are toward the end of their life, if you will. And how do we make these funding of these programs sustainable? So on behavioral health, it is not simply hospital services. It is across the continuum of care, because the goal is to make sure that people don't get in crisis and don't need the inpatient beds, but can live in the community every single day. So thank you for that question, because it really is important. And I think the legislature has made steps and focused in on childcare. Last year, actually, we created the Behavioral Health Advocate to work with patients who are having concerns on getting the care that they need. At the same time, we know that the legislature is looking to take a look at all of the different entities that are looking at behavioral health to try to provide consistent oversight, and we know that that is being done under the Appropriations Committee. So there's a lot of work being done, but there's a lot more work that needs to be done. So thank you for that important question.
Thanks, Jim. And then in addition, in the chat, I also just shared a document that summarizes some of the initiatives on Certificate of Need, because I know there were some questions earlier on that as well. Any other questions that we have?
Yeah, Nicole, can I ask Jennifer Jackson a couple of questions? Jennifer, there's been a lot of talk, certainly from the Office of Health Strategy, about these cost growth benchmarks, and that seems to have hit hard with obviously the CHA and obviously hospitals. I wondered if you could talk a bit about that and why that seems to be a bit of a sticking point with everybody. And the second part is also, the majority of hospitals in Connecticut are non-profit, and obviously a lot of them get tax advantages because of that, certainly if they own property. My understanding is, part of that being a non-profit is, well, you help the community out. That's why you're getting, a cut when it comes to not having to pay, so like, property tax, etc. So perhaps, when it comes to this whole cost thing, when you say that hospitals are under pressure, they're not paying the huge amount of tax that other organizations would do. So perhaps you can balance that out for us.
Sure. On the cost growth benchmark, certainly we think it's important conversation to have, and we've been participating, but as you raised, we have significant concern about needing to make sure that we look at all the drivers of cost. You simply can't pull out a single piece of the element of cost and talk about addressing it. For instance, commercial rates has been a focus. Well, you simply can't talk about how to reduce commercial rates or how to hold the rates steady if you don't look at the impact of the chronic underfunding from Medicare and Medicaid. And that's why we're calling on the state to reimagine Medicaid, to look at ways we can use Medicaid to invest in our communities. But importantly, as Todd talked about, we simply have to have the resources to support our community. On the question about tax exemption and community benefit, you're right. The tax exemption is afforded hospitals. It's a longstanding public policy. It's in recognition of, but it is far less than the benefit that hospitals give to their communities. And Todd talked about some of them. All of the hospitals could talk about them. Nicole certainly can share additional information, but we provide $38 billion in economic benefit to the state. We provide $3.4 billion in community benefit. We are also a huge taxpayer in the provider tax, which benefits the state. They actually accrue benefit from the payment of that provider tax.
I just want to pick up on that with you. I mean, one, can you just tell me the sources of those figures that you've just quoted? I mean, they're big figures. I mean, where exactly is the source for those figures? And also, when you talk about the benefit to the state, I'm going to pick on Yale again here, I'm afraid. I mean, Yale has a lot of tax-exempt property in New Haven, and the city of New Haven doesn't benefit as much. And this is well documented. It's had clashes with Yale University and the Yale New Haven health system about how much tax they would like it to pay. And obviously that impacts the services that the city can actually give. Now, again, this goes back to this tax exempt status of they're supposed to be helping the community.
I can tell you unequivocally that the city of New Haven and the surrounding communities benefit considerably by the presence and the contributions of Yale New Haven as a provider of care, as a provider of services to their community, and as a major employer and as a driver of the local economies. And we're happy to share more figures and information with you.
Thank you, Jennifer. And oh, sorry, Jim, go right ahead.
Yeah, Brian, I was just going to go back to the cost growth benchmark, and we have a cost growth benchmark in Connecticut. We should back up. Massachusetts is the first state that had the cost growth benchmark a number of years pre-pandemic. We put ours in just about the time the pandemic was ending, a completely different type of healthcare environment. And we established a benchmark, which is the way in which we should begin to look at healthcare. It's not meant, it's meant to be one tool as we analyze healthcare. But if we go to the Office of Healthcare Strategy's own report, right, they say that, for one example, that the growth attributed to salaries and wages is 26%. That does, and we know salaries and wages are almost 2/3 of, probably a little less than that, probably around 60% of what expenses are for hospitals. And if that's going up 26%, the 2.9% benchmark becomes concerning. So that's sort of the push and pull, if you will, on the cost growth benchmark. And those are the conversations that we're having with them. How do you work inflation into a cost growth benchmark? Same conversation we're seeing in other states. Or do you hold the benchmark where it is, but recognizing that there is going to be inflation and there are going to be things which are going to impact the benchmark? So it's that conversation that we're having. We've been at the table since day one on the benchmark. We think it's an important tool to look at healthcare costs, but there also has to be an understanding that it is a tool, and we have to take into account this new healthcare environment post-pandemic, where we saw inflation that we haven't seen in my lifetime.